Welcome to OEC Health Talks. I'm Joe Naglowski, OEC President and CEO, and we are excited for you to join us for this educational video series that dives deeper into specific health topics that we know are important to you and the OEC community. Today's OEC Health Talk tackles another important topic, helping your child who has challenges with weight, featuring Professor of Pediatrics, Erin Kelly. It can be challenging to find the right help for children with obesity. The first step is to understand the complex chronic disease of obesity, how it affects children, and the different treatment options available for children and adolescents. In today's Health Talk, Dr. Kelly will help you understand what childhood obesity is, how to talk to your child's healthcare provider about it, and the different treatment options that are available. And with that, take it away, Dr. Kelly.
Well, thanks a lot, Joe, for that kind introduction. And it's really my pleasure and honor to be able to spend a few minutes with you here talking about pediatric obesity. I wanted to start off by talking a little bit about where we are, at least in the United States and really around the world when it comes to childhood obesity. So when we talk about prevalence of diseases like obesity, what we're talking about is how many people are affected by the specific disease. In this case, we're talking about obesity. And you all, I'm sure, have heard and read in the lay media that the prevalence of obesity is high and it's going up. And in fact, that's what the research says. Right now, at least in the United States, we have about 20% of children and adolescents. So this ranges all the way from 2 years old up to 18 years old. About 20% of children and teens struggle with obesity. Now, that didn't used to always be this way. If we dial back a number of decades to around when I was born, in about the mid-1970s, we didn't have the high level of prevalence of childhood obesity that we have today. It's always been present. People have always struggled with weight management. But something changed around the 1970s in this country that started to kind of change how these trends went. So right now, we see, again, that about 1 in 5 children and teens struggle with obesity. And what is really interesting and unfortunate, I think, about the COVID-19 pandemic is that we've seen that it's worsened some of the trends in prevalence of childhood obesity. So specifically, what we're finding in the research is that the age range between 5 to about 12-year-olds, that sort of elementary age set, had the biggest increases of any age group, including adults, in body mass index or BMI. And even more unfortunate than that, what we found was, and my colleagues who did this work, what they found was that marginalized communities, minority communities, people who struggle with poverty, those are the types of individuals that had the biggest increases in obesity and weight gains over the last 2 to 3 years, which is really unfortunate. I think what has happened essentially, at least in the United States, is that the COVID-19 pandemic has really magnified a lot of the issues and disparities that we've had in our country related to obesity and all sorts of other issues and diseases. So one point I wanted to make out of the gates is that you're not alone. So if you have a child or children that struggle with their weight, that have obesity, you're not alone. Many families have the same issue, and what we're seeing is that these rates are continuing to increase. One other thought around those lines is that we now are able to track obesity in different grades. So we talk about more moderate obesity and then severe forms of obesity. One thing that we are seeing is that the most severe forms of obesity are the types of obesity that are increasing the most, at least in the United States. So when we talk about obesity, I think one important thing is to discuss is how we define it. How do we talk about obesity? How do we define it? Well, there's a couple different ways to think about this. One is sort of the conceptual framework, if you will, of obesity, separate from things like height and weight and BMI, is this thought that obesity really is at its core excess adiposity or excess body fat that impairs physical, mental health and well-being. And so that is from a sort of high-level perspective, how we view obesity. But when we talk about the clinical definitions of it, we use something called body mass index or BMI, which most of you probably are aware of. Now, it's a little bit more complicated when we're talking about a child or adolescent with BMI than it is for an adult, because of course adults are done growing. So we use absolute BMI values in adults. A cutoff of 30 or above would be designated as being in the obesity category for adults. But of course, children are a moving target. They're growing. And so we don't use absolute BMI values. We use something called BMI percentile. And what these percentiles do is compare your child to reference norms. That's a whole nother discussion, but reference norms and where they fall percentage-wise against other kids, other peers that are their same age and sex. And so what we use clinically is a BMI percentile cutoff at the 95th percentile to define obesity. Now, one note about BMI is it's not perfect. We all know that height and weight do not really give us an indicator per se, a specific indicator of how much body fat a person has. So it's not perfect. But what the research has shown is that overall, it works pretty good as a generalized screener, certainly across populations, and even for the pediatricians when they're able to look and compare against normative reference standards. But I just wanted to make that clear that we need to be careful about how we equate BMI with excess adiposity and risk, because it's not a perfect correlation. One point I wanted to make about childhood obesity is to maybe dispel this myth or misunderstanding that most kids who struggle with their weight will eventually outgrow their obesity. In other words, we should just take a wait and see approach, and that eventually your child or any child will just grow into their frame. Really, what the research says is that's not true. And it's pretty conclusive at this point that there's a high level of tracking of body weights and body mass index and adiposity from childhood into adulthood. And what I mean by tracking is the likelihood of, if you have obesity as a child or adolescent, what your likelihood of carrying that into adulthood is, what your likelihood of having obesity in mid and later life is. And what the research shows, the longitudinal studies that have tracked kids over time, is that it tracks very, very strongly, which again sort of pushes back against this notion of, oh, the child will grow into their weight. That typically does not happen. I'm trained as a physiologist, meaning I was trained about how the body works, interacts, all the physiologic systems in the body. And one of the things that I have started to become convinced about is that if weight management struggles start to surface in childhood, and this is my opinion, I don't have a lot of evidence to support it yet, is that probably it's a sign of a person who has a more aggressive form of the disease of obesity. And the reason why I say that is we know that kids tend to be expert, what I would call physiologic compensators. In other words, in the context of excess calories that we have in the environment, I'll talk a little bit about that in a minute. Kids who have physiologies that are malleable and have the plasticity to deal with it, even eating excess calories and being surrounded by all of these calories, are able to manage the body weight properly. And what we see with kids who struggle with their weight is that they probably have a physiology that is less able to properly deal with all of the excess calories and environmental influences that are surrounding them. Meaning that it probably, to some level, explains this tracking, right? That you don't just grow out of your obesity, that if you see this sort of canary in the coal mine early on, of early onset obesity or struggling with weight, that it's probably going to be a lifelong struggle. And I don't say that to discourage people or try to be a downer about this, but more just the reality of what we're seeing in the research and what my colleagues see in clinical care. So this goes to early identification and doing something proactively early on, which I'm going to finish with at the end of my discussion with you all. Thinking about what are the causes of obesity. So one thing that I'll tell you is that, every day we read in the newspapers online that, it's soda pop that's causing obesity. Or, it's, lack of recess time in schools that are the main cause of obesity. The fact of the matter is there are many, many, many causes of obesity. And so I would encourage you to be skeptical anytime you read or hear something like that about one or two factors being responsible for where we are today with the obesity epidemic. It's probably not true. I could probably sit here and bore you and list off, about 175 factors that the research has shown contributes to the development of obesity and the perpetuation of obesity. So it's multifactorial, and that's one of the reasons why I think weight management is so darn hard, is that we're swimming upstream against so many different factors, most of which are beyond our domain of control. But the environment certainly does play a very large role. And going back to my comment about when we saw this increase in the obesity epidemic, it's not coincidental that there were many societal changes that started around that time that continue today. Things like the fact that there is not as much recess and physical education time, the fact that there are not as many sidewalks and open spaces as there used to be, the fact that the food that is the most calorically dense tends to be the cheapest type of food, so there are socioeconomic factors at play. There are just so many countless environmental factors that make this so difficult for all of us to try to manage. But back to the fact that I mentioned earlier that I'm a physiologist, I very much see the development of obesity, even in childhood, as primarily a biological issue. One of my colleagues, who I think some of you know, Ted Kyle, always talks about how our biology sort of sets the table, and the environment serves it up, and serves up the meal. And I think that's a good analogy to think about this, that biology really does play a strong role in the development and perpetuation of obesity and resisting our attempts at weight loss. And I'll talk a little bit more about that, about the biology's resistance to weight loss when I talk about treatments in a couple of minutes. Shifting gears a little bit, I wanted to spend a couple of minutes talking about body positivity and the movement therein versus the reality of obesity and its consequences. I think many of these discussions are starting to surface right now about how do we walk this fine line, especially because today we're talking about children and adolescents. How do we walk this fine line about identifying obesity early on, raising the issue, and then working on that without upsetting the child, the parent, the family members about that, and implying that somehow we are criticizing their willpower or their body type, this type of thing. It can be really, really challenging and tricky. I would say that in many ways, our biological view of obesity is in line with the approach of destigmatization. In other words, it's not your fault if you have obesity, right? No one chooses to carry extra weight. And so engaging in those types of conversations while being empathetic and sympathetic about this is important. And I say this because I do firmly believe, as a scientist and knowing what I know about this disease and its consequences, that I don't think we can walk on eggshells about this. I think we need to be open and honest with each other, and healthcare providers need to be open and honest with the patients that they manage and are responsible for. But it needs to be done in a really delicate fashion, and we need to be careful that the words that we use when we bring this up are not going to worsen any sort of mental health challenges that these kids already have. Transitioning now into misperceptions about obesity within the general public and even in the healthcare setting, in the medical community, it's pervasive. It is extremely pervasive. We know in society that really obesity is one of the last areas where, this is me talking, it seems to be okay to criticize and to stigmatize and to bully. And, in many ways, I see obesity having a parallel to the field of mental health 20 or 30 years ago, where, if you dial back then, there was a lot of misunderstandings, misperceptions, bullying, criticizing, stigmatization about mental health. And then in that field, there over time was a recognition that this is not, people don't choose to have depression or choose to be anxious. We know that there are real issues with neurotransmitters in the brain that drive these processes. And I think obesity is 15 to 20 years behind the field of mental health in this way. There seems to be a lot of misperception that if people just pulled themselves up, tried harder, ate less, and moved more, that they would easily be able to manage their weight. And again, the science really could not disagree more with that statement, especially in terms of the biological origins of obesity. And so this is something that we really have to address and be aware of and acknowledge, not only for our own sort of implicit biases, but we need to make an effort to educate those that we know, those that we love, about what obesity really is. But this extends also into the healthcare arena. I'd like to say that all of my clinical colleagues who are in different subspecialties or in general pediatrics all understand obesity being a chronic, refractory, relapsing disease, primarily of biological origins, but they don't. We have a lot of work to do. And so I just want to frame that the right way as we start talking about treatments in my next segment here, that this is going to be an issue that you probably will have to deal with your healthcare providers, acknowledging that they may not have a complete and full understanding of what obesity really is. So I want to move now into treatment options, and I want to make you aware of some, I'd say, major progress that we've made just in the last couple of years, and really excitingly, where I think we're going to be in the next 5 to 10 years in terms of obesity treatments, particularly obesity treatments for children and adolescents. So when we talk about obesity treatment, we think about it in terms of comprehensive care, that it's not just one treatment or two treatments, it's the whole gamut should be open and available to every child and adolescent that struggles with obesity and weight management. But most of us would consider lifestyle modification and behavioral therapy, behavioral counseling, as sort of the foundation of all obesity treatments. And having said that, I would say by itself, things like dietary counseling, physical activity counseling, and behavioral modification, those are sort of the three pillars of lifestyle modification therapy. They're important, but by themselves, the research shows us typically do not lead to clinically significant or meaningful and durable weight loss and weight management in children and adolescents. It just simply isn't enough. So engaging in healthier lifestyle behaviors is necessary, but I would argue insufficient by itself for long-term weight management for most children and adolescents, not all, but most. Particularly for children and adolescents that struggle with severe obesity, it's not going to be enough. So in addition to lifestyle modification therapy, we now, and this is what I was talking about a second ago, in the last couple of years, we now have some anti-obesity medications that have shown to be safe and effective in adolescents, in teenagers. And one medication we published about a couple of years ago, it's branded as Saxenda. It's a once-a-day subcutaneous injection. And this medication works by suppressing appetite and also enhances satiety. And it does that by slowing how the transit of food through the gut. So it makes people feel fuller for longer. So this medication, Saxenda, is now approved by the US FDA as an obesity treatment for adolescents ages 12 to 18 years old. And it's been approved for adults 18 and over for many years now. And then hot off the press, we finished another study just a number of months ago of a combination medication, phentermine and topiramate. It's branded as Qsymia. And this medication is now also approved by the US FDA for the treatment of adolescent obesity. This medication works by not only suppressing appetite, but also, we think, by working on some of the reward pathways in the brain. So when we think about eating and food and cravings, we think it probably works to push back against some of those things as well. And so this medication now is also approved for adolescents ages 12 to 18 years old. And now that these are FDA approved, it's a major milestone. It's a major step because pediatricians now can, with confidence, prescribe this medication to their adolescent patients who struggle with their weight. So I should say, in addition to that, we have a number of other medications that I think are going to be as effective or even more effective than the medications that I just mentioned to you. And to give you a little bit of sense of how well they work, in research we look at averages, we look at means, and no specific patient is going to respond exactly the same way. But the results of this Saxenda that I talked about earlier, on average, you get about 5% reduction in BMI for teens. And with Qsymia, the second medication I mentioned, you get about 10% at the top dose BMI reduction at 1 year in teenagers. Some of the newer medications I think are going to be even more effective. We should have another one that we're going to hear the results about just in the next month or two. So that will be super exciting. And we'll see if the FDA approves that one, hopefully sometime in the next 6 to 12 months. And then there's a whole pipeline of other medications that are being studied right now in adults that eventually we'll be able to do the pediatric trials that I think are going to get us into the 15, 20, 25, 30% BMI reduction range, which is going to be super exciting. Now, I've been mentioning teens and adolescents a lot in relation to these medications. We're getting there, but we're not there yet in terms of finishing the studies and hopefully getting the FDA approvals for these same medications in kids who are younger than 12 years old. That's not to say that they are not accessible, because physicians, including pediatricians, are allowed to prescribe medications that are FDA approved for other ages or different uses, in this case for younger kids. It's called off-label prescribing, and I'm not going to say that physician should necessarily do that or not do that. But it is an option. And so if you have a child who struggles with their weight that is under age 12, it would certainly be worth a conversation with their pediatrician to talk about all the options available, including medication, if they deem that to be appropriate. And then taking one more step when we talk about comprehensive treatment, in addition to lifestyle therapy, medications, there's also bariatric surgery. That phrase scares a lot of people, and they cringe when they hear that, because it is a surgery, and most of these surgeries are irreversible. However, from an evidence perspective, from the research perspective, far and away right now, bariatric surgery is the most effective and durable treatment for severe obesity in adolescents. And so it is definitely something that should be talked about or considered. Maybe it's not the right time to consider that. Maybe the severity of obesity is not there, but it definitely should be on the table as a potential option for youth with severe obesity. The American Academy of Pediatrics, which is the main flagship pediatrics organization in the US, came out with what they call a clinical practice guideline on bariatric surgery a year or two ago. And we're very supportive of the idea of considering bariatric surgery for adolescents who struggle with severe obesity, and even for kids younger than adolescents, depending on what other complications or comorbidities go along with their obesity. So all of those are potential treatment options that ought to be discussed. One concept about treatment that even many of my pediatrician colleagues do not fully understand is that obesity is a chronic disease. It's a refractory disease. It's tough to treat, and it's relapsing. And what I mean by relapsing is it doesn't just go away. You don't just try hard for a little while, lose some weight, and then just go along your merry way. No, it doesn't work that way. It's like other chronic diseases. You can talk about mental health, which I talked about earlier. If you struggle with mental health, you probably struggle with it for your entire life. You don't just treat it for a few months and then take the treatment away and expect that everything's going to be honky-dory. It just doesn't work that way. And so this is one concept that I hope to convey to you and even help educate healthcare providers when you interact with them, is that obesity treatment needs to be lifelong. Like I said, if obesity surfaces in childhood, it probably is a sign of a more aggressive form of the disease. So we should never be letting our foot off the gas pedal here. So when we talk about lifestyle therapy, it should be lifelong. If your physician decides to prescribe an anti-obesity medication, as long as it's working and the effects there aren't side effects and it's tolerable, it should be used lifelong. Bariatric surgery obviously is an irreversible treatment, so that it's lifelong in that sense. But just understanding that this is not a short-term proposition. This is a long-term haul. I wanted to just speak a little bit about the challenges of access to specialists and treatments. In relation to medications, which is most of the work that I do is around anti-obesity medication development for children and adolescents. Mostly those medications, at least at this point, are probably going to be prescribed in the context of specialty weight management centers. So pediatricians who specialize in obesity medicine. It's not to say that primary care pediatricians won't prescribe it, but I think many will be reluctant to prescribe anti-obesity medications. For the time being, as long as this is the case, it's going to be a little bit problematic in relation to access. So most of the tertiary care or specialty weight management programs for children and teens are located in the big cities like here in Minneapolis or in Boston or in LA, Chicago. And many kids and families that struggle with obesity are not within traveling distance to many of these sites. So access is going to continue to be a problem here. And we're working hard on that to try to train primary care pediatricians to be able to confidently prescribe medications and provide obesity care. But I think, frankly, we're a little ways away from that. So keep that in mind in terms of access, that if you have a child that struggles with obesity, it may be a challenge to try to find these providers. But I would encourage you to, if you have a specialty weight management clinic within reasonable driving distance of your home, to go seek care from the specialist who can really help you out and have the best shot at helping your child properly manage their weight. So as I wrap up, I wanted to leave all of you who are parents with a couple of thoughts about helping your child with their weight management journey. And so what can you do as a parent? The first thing I would say to you is cut yourself some slack. Don't feel guilty. It's not your fault. There is, again, back to misperceptions, this thought that somehow, if there's a kid that struggles with obesity, we just need to look to their parents. They're the ones that are feeding them and made these choices that led to this. That could not be further from the truth. It's just wrong. And so I would say, first of all, cut yourself some slack. You are not a bad parent. I'm a parent myself, and no one wants to even have the implication that they're a bad parent. And you are not a bad parent if you have a child that struggles with obesity. Second is be informed. So hopefully I've given you some nuggets that you can take home about obesity and its causes and the treatment options that we have available. But the more well-informed you can be as a parent about what obesity is and what the treatments are that are available, the better off that you're going to be. Third, be proactive and don't wait. This speaks to my earlier comments about waiting to see what happens, the wait and see approach, to see if my child will grow into their obesity or somehow just snap out of it. I hope that they do, but the likelihood is that they won't, and that they're going to struggle with their weight for the rest of their life. And the earlier that we can start the process of getting them effective, safe, and durable treatments, the better off they're going to be. I often use the analogy of stock portfolio investments, right? The money managers will tell you the more money you can put and invest early on, even if it's not a lot, if you can get started early in your stock portfolio in your retirement, it's going to pay huge dividends over the decades and years. And I think it's we can think about obesity and health similarly, that if we can make changes earlier, it's just going to greatly improve the long-term prospects for your child to live a long, healthy, happy life. And so getting on the stick early, I think, is really, really important. Don't wait. Next, I would say expect and demand proper care and support. Do not tolerate the pediatrician who wryly smiles and says, well, you need to just start eating less and moving more. Don't let that be the end of the story. Be informed. Be ready to respond to something like that, and demand proper care and support. Demand that your physician, in a nice way, right? But demand that your physician tell you about all of the options that are available for weight management, including lifestyle, medications, and surgery. And if your pediatrician doesn't know about medications and surgery, kindly, in a courteous way, ask them if they could get themselves informed. There are many options for physicians to get continuing medical education on these issues, and let's just face it, they need to get with the program. And then finally, I would say if you are so inclined, take action and advocate, right? The Obesity Action Coalition is awesome, and they train people to be informed, educated, and empowered. And I'll tell you, I think the OAC is planning to really move now more toward adolescents and children in its programming and its advocacy efforts and its educational efforts. And we can use all the voices that we can get. So if you are so inclined and want to take more action on this front, to speak out, the voice of the lived experience can be extremely, extremely powerful in terms of us moving the science forward, in terms of moving the legislation forward to help expand access to treatments. That could be really, really important. So anyway, I'm just going to end there. I really appreciate all of you taking time to listen. I hope that I was able to convey a couple new things that maybe you didn't know before. But it really was a pleasure and an honor to be able to do this presentation. Take care, everybody.
Thank you, Dr. Kelly, for providing us with such helpful information on childhood obesity and the different treatment options available for children and adolescents. The OEC has a variety of educational opportunities for you throughout the year, but one of the best places you can turn for quality, unbiased education is our resource library. Simply visit obesityaction.org/library and check out our videos, brochures, articles, and more health talks. Also, be sure to subscribe to our YouTube channel to get notified of any future educational events and broadcasts. Thanks for joining us.